Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to tonight's edition of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet, broadcasting from rural New South Wales in Australia, 2 hours outside of Sydney. And tonight I'm talking, my special guest is Kandra Sellers, who is in the Midwest of the United States. So it's yesterday there, and it's coming up to 7 o'clock her time. Kandra, thanks for being a guest on the Ultimate Dental Podcast.
Absolutely. I'm super excited for this.
Kandra, now you came onto my radar because you're a medical billing specialist. And I like the idea of that because often in dental practices, dentists don't know what they can be paid for and how they can help their patients in terms of getting subsidization from procedures which are outside of dentistry but inside of health, because dentistry is really health. So let's talk about how you ended up in medical billing, but also you began in your dental career as a dental hygienist as well. So you've been in the dental space for most of your adult life, and as have I, and you've seen some things, and you know, we could have recorded a podcast in just our chat beforehand. We spoke for that long, so let's start with the hygiene, and then how you've ended up where you are now.
Yeah, so I have been. I'll just say it. I know you you don't like to say how long you've been in dentistry, but I've been in dentistry for over 35 years, which kind of ages me. But in that time, I'm proud of that because I've done a lot in my career that has molded me into what I am today, and I am so passionate about our profession, and I think it's such an exciting time of dentistry to be in our profession. So fortunately, I've had great mentors along the way. I've had a lot of different roles in dentistry, from clinical and actually with a lot of specialty clinical. So perio, pros, cosmetics, more specialty than general dentistry. And I love that. I could work perio, 12 hours a day nonstop doing periodontal therapy. I loved it. But and then I was in sales. I did consulting. And now here I mean, I've done so many great things. One thing just led to another, and I had so many great opportunities. But I've landed here in medical billing, and I cannot wait to see our profession grow in medical billing and for the medical community to finally realize the importance of what we do and how we impact people's overall health, because there's still a huge disconnect.
Yeah, dentists. When I started as a dentist back in the 1980s, after starting dental school in the 70s, dentistry was nicknamed really tooth panel beating. That's what they thought we did. We just, fixed up teeth, and there was no oral systemic link whatsoever. That was just by coincidence that people who had bad general health habits also had bad oral health habits. That was just
Yeah.
how it was thought, even by leading dentists. But more and more, we're getting that connection. And that's why it's exciting talking to you, because there are so many things that we can see inside the mouth that are indicative of systemic conditions that
Hmm.
we need to be on top of those things. And, we were talking before, and we'll talk about it now, in terms of um, dentists are really in a situation where they're not just fixing teeth, but they're in a powerful position where they can identify things that can save people's lives if they identify those early. So one of the things that we were talking about was oral cancer screening, the rise in the incidences of oral cancer and the causes of oral cancer, and dentists really needing to be on top of those sort of screenings and investigations and identifications, because early interception and early um, diagnosis is the key in saving our patients' lives.
Yeah. And as you were talking about the initial piece here before you hit the word oral cancer, it popped into my brain. Before oral systemic connection was ever made, I had already made that in my career. I had already identified that. I like I mentioned, I love to do perio. And I had a patient that she had come to me as a new patient. She hadn't been to the dentist for a few years. She had been newly divorced, new job, lot of changes. And she hadn't seen her primary care physician. She hadn't seen her dentist for a long time. Came in, and lo and behold, she had periodontal disease. Imagine that. And just profuse bleeding. And this is a professional woman who actually really did take good care of her health and good care of her oral health. And I did SRP on her, um, and she did not respond to that. I always had good response with my SRP. We put her on, at that time, Periostat was a big thing, so doxycycline. um, at the very beginning, I had mentioned to her, you really should go see your primary care doctor, just get a good checkup. And then when she didn't respond to SRP or Periostat, and like her plaque score was next to zero. And I'm like, dang, she's doing everything she can do. I'm doing everything that I can do, and she's not responding. And so she had she was okay with going to see her primary care, but she just wasn't. She just, you know, she came back for her re-eval, bleeding like crazy, very little plaque. We did this a couple times with 3-month recares, and finally, on a day that she was not appointed for, she walked into our practice asking to talk with me. And so I went out, met her, and she said, I had to come and thank you, because it's because of your persistence of telling me that I needed to go see my primary care that I did, and I have leukemia. And I knew there was something wrong. From that point on, I never looked at my patients the same. If we are doing all that we can as a hygienist to support their periodontal health and they're not getting better, there is something wrong internally, and they need to be seen by a primary care physician. Unfortunately, many primary care physicians don't understand this connection. And it's that way with oral cancer too. But I made that link many years before we started talking about oral systemic connections, and I never looked back. But that shaped me into my passion for this whole topic. Um, it's just it's we have we have to look at the patient as a whole. We really
Oh,
do,
you do, and
and we have to advocate for them, and we've got to educate them. Something's not right.
sometimes we have to shock them. I remember somebody once saying to me, the blood that's pumping through your infected gums is also pumping through the inside of your heart and your lungs
Absolutely.
and your body. And
Within a
that's,
minute.
yes,
One
that's the
minute.
scary stuff. And it's
Yeah.
the same. You got an infection in your tooth, you're producing white blood cells in your body to try and fight that infection, and that's not
Yeah.
good for your body. You're going to
Yes.
wear out. There's only so many
We
white blood cells you can produce before you wear that out.
well, and we also know that an infected tooth can cause a heart attack or stroke.
Mm.
So there's two things that increase the chance of a heart attack or stroke by 50%, and that is periodontal disease and an abscessed tooth. And so 50% of heart attacks and strokes that could be caused by an oral infection. Bale-Donine have proven that. Um, that being said, I also know that people die from those periodontal infections. I have a friend that's a transplant nurse, and unfortunately, she sees the end result of that. And she's like, you have no idea how often that happens. Patient goes to the ER because they don't have dental benefits and they have a toothache. So they go to the ER. The ER says, I'm going to give you a referral to a dentist. You need to go see a dentist. They didn't go to the dentist in the first place because they didn't have these things called dental benefits, which aren't good anyway. They're a coupon plan. That's all they are. I'd love to use profanity with that, but I won't. But it's a coupon plan. That's all it is. It's a benefit. It's like getting a discount on your work. That's about it. But they didn't go there in the first place because they didn't have this dental benefit, or I think a lot of patients, and we've molded patients here in the US to this, a lot of patients think they can't even go to the dentist if they don't have a plan, so they go to the ER, but the ER can't help them either, and they end up back at the ER, and some of them die. Something so preventable.
It's crazy. It's crazy, that disconnect, because of the supposed belief that they're
Yeah.
either covered or not covered, and
Mhm.
insurance is a whole other topic that you could go down a rabbit hole about. Ultimately,
Mhm.
the and I say this to dentists all the time, whenever you've got the provider of a service and the receiver of a service, and that's the pure relationship, that's a much cleaner relationship than when you put
Mm.
intermediaries in, be they insurance companies, government assistance. There is always exploitation on both sides, by the provider to get more pay and by the receiver to get more than they're supposedly allowed to get. And that that tarnishes the relationship right from the start. You've got a guy mowing your lawns. It's just you and him working out the price, and he does the service. If he does a good service, you don't care what he charges, because you're happy with the service. So now we're
Yeah.
getting into customer service more than anything.
Yeah.
But insurance
But
in
it's
in
true.
insurance in
It's
dental
true.
is just like, you know, don't lose your benefits. So everyone does an end of year rush, but
Oh yeah, I'm getting those
it's
emails
crazy.
already.
But your role as a medical billing specialist is to help, I guess, in this, as we mentioned, the oral systemic link, is to help dentists realize that they need to be screening their patients for conditions that are visible in the mouth, that indicate, like this leukemia, that
Mhm.
there is something else wrong.
Yeah.
Uh, and I remember a
Right.
friend of mine saying that he had a patient present with a sore jaw, and he couldn't find anything. He referred them back to their doctor. She'd had a mild heart attack, and
Mm.
so she went into hospital to have bypass surgery. So
Mhm.
his alertness to say, you need to find out exactly what it is, prevented something bigger happening for her. And so,
Yeah. He potentially saved her life.
mm, that he did. And so it's really important that if dentists are aware that they can be billing for general health issues that are dental related to a medical um, cover, that's going to help their patients, and they need to be aware of that. So we were talking beforehand about how, and we're coming back to the oral cancer side of things,
Yeah.
how there are certain oral cancer tests that dentists aren't aware they need to be doing. that even some doctors aren't aware that dentists can do, like the fluorescent test, that again are helping to pick up um, people in precancerous uh, markers that show that they're a high risk. And that's really,
Right.
really important. So, can you talk about that and how medical billing is actually helping uh, the patients? Obviously, because we're going to keep more patients alive. And it's also going to help the dental practices as well in becoming known for their thorough diagnosis. Because people sit
Mm-hmm.
around at dinner parties and at barbecues and saying, your dentist does all that, mine doesn't do that. And it's
Mm-hmm.
kind of like, I need to be going to that guy because he's on top of his game.
Yeah. I feel like, and this isn't everybody, and I think your audience probably isn't in this category, but I feel like our standard of care in dentistry is a grade level C at best. Um, I feel like the things that we should be screening for, like oral cancer, is something that's lacking. And I believe a lot of it, at least here in the US, comes back to what we're being reimbursed for our evaluations. Our reevaluations, on average, I'm seeing about $30 for a periodic eval. I don't know any MD that's going to work for $30. They're not, nor should we. We are a medical specialty, and the things that we do are important. But one of the ways that we can get better reimbursement is by billing to medical. And often when I look at practices and their numbers, and I look at this periodic eval and I see $30, that is a code that we can bill for, but the insurance is only going to allow us so much money for that, and that's it. There is no more money for that code based on that insurance policy if you're in network. But what if we had a sliding scale on that code, like medical does? Medical doesn't have limited evals. They don't have comprehensive evals. They have new patients and they have established patients. And the reimbursement is based on the medical decision making of that encounter, as well as the time spent with that patient. And that would be FaceTime and non-FaceTime. That's a very different concept than us using this one code that allows reimbursement. And as a hygienist, I look at, if I saw a patient that was 8 years old versus in the morning, say, and in the afternoon I saw an 80-year-old. If I use that periodic eval code, I was paid, the dentist was paid the same amount for the 8-year-old and the 80-year-old. That's a completely different encounter, completely, in so many ways. But that's the reality of what we've created with dental benefits and how it works. But in medicine, we could actually be reimbursed based again on that medical decision making and the amount of time, FaceTime and non-FaceTime, that we spent with that patient. So that's a completely different picture
How
in
difficult is it
reimbursement.
for dentists to access the medical reimbursement in the United States? How is it difficult? Is it a difficult process?
No,
Some may not even be aware that they can do this.
exactly. They're not aware that they can do this. Now, um, in every state it's a little bit different depending on the payers in that state, but I mean, most of the time, if I'm with a practice that is well established, we just start submitting claims, and guess what, we can retro bill up to 365 days for most of our patients. So say a patient was in today and we did a maxillofacial and oral cancer screening and we did a sleep screening, that would give us enough reason to bill to medical. And if we had done that on the exam 6 months prior, guess what, we can retro bill that too. So and are things going to go to deductible? Are they going to go to copays? Are they going to go to coinsurance? Sure they are, but we are the only medical specialty in the US that has two places to go for reimbursement, and that would be dental and medical. We're the only medical specialty that has two places to go for reimbursement. So now we can have potentially different levels of evaluations based on that encounter with that patient. It has nothing to do with age. It has to do with the encounter and what we did during that time. Um, and and it's really just that simple and tapping into medical. Now obviously most of my providers are out of network, and there are some payers that don't allow a general dentist in network, so we're billing as an out of network provider. But there are ways to go in network as well. Every state's a little different. There are some payers that if you're in network on the dental side, you're automatically in network on the medical side, and there's pros and cons to both. But you know, it looks completely different when we start billing like that than just taking dental benefits that are so limited. And if you look at most patients' treatment plans for a year, especially if you're an oral surgeon or a specialist, now you've maxed out the patients. There's rarely a treatment plan that's under $1,000 at one of those specialties. Endo is another one. Now we've maxed out the patient's benefits for the year, and they can't go back to see the person that the doctor that referred them, and they still need more treatment. So where are we going to get that monies from? There are many things that we can build to medical, but it's just a whole different idea and concept that a lot of people just don't know how to navigate or how to get there. And we have a very limited mindset about dental. We've been kind of brainwashed by this thing called dental benefits, and it's what we know, it's what our patients know, and we don't think outside the box beyond that.
Yeah, I think we've got to get the dental profession thinking outside the box again, because it's for our patients' benefits. And and Kandra, you just mentioned too that um, sleep apnea is
Mm-hmm.
something. An oral condition that manifests itself in breathing issues, snoring, um, as well as grinding and clenching. And every
Mm-hmm.
dentist knows how to identify grinding and clenching, but they put it
Mm-hmm.
down. They often put things down to stress. But I know when I was practicing, I used to say, well, young children grind their teeth, like little infants grind their teeth. And what
Yep.
have they got to be stressed about? They haven't got wives, girlfriends, mortgages, bosses. They got no stress. You know, all they're worried about is where their next meal's coming from and whether they can get on the PlayStation. So they grind their teeth because they've got an airway issue, and that's that sleep apnea thing. But sleep apnea is also a very undiagnosed sleep apnea is a big killer of men in their
Yes.
50s. And as a child, I remember saying, oh, I don't want to die of an illness. I don't want to die in my sleep. Oh, you die in your
Mm-hmm.
sleep, you've died 20 years, 25 years sooner than
Yeah.
you should have as well. And again,
Well,
that's the scary thing. You've got to scare patients to say, you need to treat this unless you want to die 25 years younger.
and how many children are on ADHD or behavioral medications? 50, I think it's 50%. I mean, it is crazy how many children are on medication because they have ADHD or ADD, or they don't listen, and um, we have a big problem with airway in children and adults. I I'm not going to go down that rabbit hole what I think, but we they both need to be screened, and we're doing a better job screening on adults, but we're still, most practices are not screening for children. And it's our wheelhouse, and the ADA has put that on our shoulders, and their MDs are not, they're not looking at that. They don't know what to look for. They don't know our space. We're the only ones that spend the kind of time that we do with our patients to be able to evaluate that. But again, we're on this hamster wheel of all of these things we got to evaluate. We have maxillofacial and oral cancer screening. We have periodontal disease. We have sleep apnea. Those are just those are the three big things that we're responsible for screening for, but we're not reimbursed to screen for that um, at $30 a pop. That's just not realistic. We're reimbursed so little on the dental side that we have to go faster, which is, it's not good for our patients. It's not good for our practice profitability either. I am thinking of profitability. There's somebody in our industry that has been pretty vocal on Facebook with his cancer journey. And at the beginning of this year, he posted that he basically had, for his cancer therapy, it was about $1 million in treatment that year for 2023. And I thought, wow, that is one person contributing $1 million, that his insurance company paid $1 million to his medical team. We have to see 1,000 patients to max out their $1,000 allowable amount per year to be $1 million practice. Here, this is one patient that contributed $1 million. One, we have to see 1,000 and get the maximum benefit on every one of those 1,000 patients to be $1 million practice. What the heck? That hit me like a ton of bricks when I saw that. We work so hard and we take such good care of our patients, but there is another way. We deserve to be paid as a medical specialist. We are a medical specialist and we're not reimbursed like one.
It's crazy, and we're looping back to this: what's best for the patient and what somebody will pay to help them. And we can touch briefly on the fact that some prescription medication is government subsidized, and if they had to pay for it privately, it would be tens or hundreds of thousands of dollars, but it's only $50 because it's subsidized. But in terms of treatment, and back to your days as a hygienist, same thing. People would say, I'm only covered for 2 cleans a year. And you just have to call it. You just say, well, if you want to just get 2 cleans a year, you're going to lose your teeth. If you want to keep your teeth longer, you're going to have to pay for the other 2 cleans out of your own pocket. Your decision. You've got to go. You've got to go to the worst case scenario and take the insurer out of it. But in reality, that's decision, as I like to say down here in Sydney, that decision is made by a bean counter who sits up in a 50th floor office looking over Sydney Harbour and deciding whether somebody's going to get a rebate of 50 cents or 55 cents, and that extra 5 cents can mean millions or tens of millions of dollars to the insurer if they just knock that off. And so it's the profit to the company that goes to the shareholders, but at the end, the consumer is the loser. And so we've, as diagnosticians, every dentist that who works in a fee-for-service practice says how nice it is not to have to deal with insurance companies. And yet dentists who are struggling always say, well, if I get an insurance company, they'll just send me the patients, but you've got to pay them 40 or 50% of what you do. That's a lot of money for a new patient. It's crazy. But ultimately, as practitioners, our role is to do the best thing for our patients. And back to the medical billing, if we can get subsidization for those tests, that's really, really important. The sad thing as dentists, again, for a lot of those things, those systemic issues, is that we can help diagnose those and then the patient disappears to be treated for those, and we don't even get to do the dentistry for years down the track. So it's kind of, dentists are saying, why would I bother looking for that stuff? It's just going to push patients out my door into somebody else's office. The teeth aren't their priority. So it's a screwed up sort of system that we're working in.
It is. I mean, when I worked in perio with the periodontist, we'd see patients way too late By the time we saw them, they were losing their teeth. And I really feel like, looking back at that, it was that mentality of they were afraid. The general dentist was somewhat afraid of letting that patient go see the periodontist because they knew now, and now like with implants and things like that, great. The patient pays $5,000 for, bone grafting, implant, the final prosthesis, whatever. And now they can't even see their hygienist for the rest of their teeth. Like this is it. It's backwards. It makes zero sense. It doesn't, it's not sustainable and it's not the best thing for the patients. And you keep using the word dentist. I hate that. I hate being called a hygienist, actually. We are oral professionals. We're oral physicians. We're oral, whatever. A dentist to me equals teeth. Dentist equals teeth. And we're so much more than that anymore. A hygienist, okay, with COVID, we all got very good with hygiene, washing our hands, cleaning our houses, disinfecting. We don't just clean teeth anymore. We're oral healthcare providers. And a hygienist, the term hygienist is somewhat insulting to me. I mean, I'm not mad at you for calling me a hygienist, but I think we have to market ourselves different. Like look at your websites and call yourself what you are. You're an oral physician. You are a
I
medical
like the term
specialty.
physician.
You
I like the
are.
term physician because down here, the hygiene degree has been replaced by a degree in oral health therapy. But the word
Love it.
therapy the word therapy kind of,
Therapy is, yeah.
yeah, I'm on the couch, I'm going to tell you my problems. And it's kind of like, I know we have physiotherapy, which is physical therapy, but that word therapy is kind of like, oh, I need some, I have some mental problems that I can't sort out. So,
Well, and they
it's
do
so
tell us
long.
all those too. They do
Yeah,
tell us all those stories when they're in the hygiene chair too.
yeah,
But
that's it. In fact, I was talking to an OHT. We actually abbreviate it to OHT because we just so that we don't have to say the word therapist. But
Mm.
she was saying, oh, if I started telling her about what was wrong with her teeth, she started telling me about what was wrong with her life, and then I never got anything done on her teeth. And I'm going,
That
maybe
does
that's what.
happen.
Yeah, that just happened. Anyway,
I
so
tell you what though, even when patients start down that rabbit hole with us, um, and we are reimbursed on time, we can let them talk about that.
oh, for sure. As long as you are reimbursed on time, that's the most important thing, as opposed to this is the procedure you had and you've had that procedure.
Mhm.
I went to my medical doctor yesterday, and I had three things to discuss with her, and she said, "You've run out of time." Yeah, like she said, I'm still billing you for the short appointment, and and we're just chatting about I needed a review on some shoulder surgery, and a couple other little things, and of course, when I go to the doctor, people say, "How are you?" I'm fine. You know, but then the reality is, if you're fine, you wouldn't be at the doctor as well.
Right.
Yeah, I feel fine, but
Well,
who's to know?
that happened to me too. Once I was seeing my primary care doctor, and I go in with a lot of questions. I expect a lot from my care providers. I just do because that's what I did as a clinician. I gave it my all, and I was asking a lot of questions, and he's like, I'm going to have to increase the level of exam today because you're asking a lot of questions, and I'm not kidding. That's how he said it to me, and I was like, I don't care. I'm going to owe you a $15 copay. I don't care. You charge me whatever you want. My insurance is going to pay you. And I said, "Do you understand what I do for a living?" And he's like, "Well, you're a hygienist." I said, "Well, I am, but I actually help dental practices with implementing medical billing." And he's like, "Oh." And I said, "Do you know what a dentist on average gets paid for a routine evaluation?" He's like, "No." And I said, "Try $30." And he's like, Oh, okay. I guess I'll stop complaining. Like, yeah, you ought to stop complaining because he got about $300 for my evaluation.
Wow. Yeah,
And he
that's
certainly did not spend an hour with me.
yeah, that's not fair as well. That
Nor
it's
did he tell me what that cost was going to be. I was at a dermatologist yesterday, and I said, "Oh, and by the way, I've got this little spot back here. I can't see back there. Can you look at it?" He's like, "Oh yeah, it's you've got a little cystic lesion back there." And he said, "Do you want me to take it off?" And I said, "Well, what do you think?" And he's like, "Well, it's up to you." I said, "Yeah, I constantly bugs me." So he got out his little razor thing, he popped it out of there. I get up to the front desk, and nobody has talked to me about cost, okay? I get up to the front desk, and she's like, "Looks like Dr. Scott did an evaluation on you today. It's $280. What? What? Okay, well, he didn't charge me for the little removal here, which he probably could have as well. I really, she's like, "Let me get your medical card and we'll bill it. But just know if they don't cover it." She said, "Well, actually, you've met all your out of pocket this year," because I did have a major surgery. So I knew that. So I know I won't owe them anything. But he didn't bother. Like, we're so good at dentistry of like giving our patients to the penny what they're going to owe. And if we go over that penny, they are upset with us. That's not how medical works. I mean, I just had this big surgery. Not one person told me how much it was going to cost for all of it. I was in the hospital for 5 days. I didn't even meet some of the people that are billing me. We're up to about $100,000 now that's been billed to my insurance.
mm,
It's like, and all we're trying to do is grasp that $1,000 benefit from every patient that comes through our door. What the heck? I just, the longer I do medical billing, I just don't understand our profession. We give so much away because we know that dental's not going to pay for it. So we feel we love our patients. We have a relationship with them, and we feel bad asking them to pay for the things that we really should be asking them to pay for.
the other
Um,
thing, Kendra, and it's probably the
but there
same in
is
the
there
United
is
States
other.
as here, and that is that there aren't enough dentists to cause that if the government changes rules, that the outcry by the dentists isn't enough to cause a swing of a government. But if it were
Mm,
nurses or teachers, that can change governments because there's so many of them. And the
mhm.
other thing is that, and I learned this very quickly in dentistry, that no matter how badly a dentist is hard done by, nobody cares. The public don't care at all. Their belief is, oh, you make enough money. So
Yeah,
when I tell people that I actually coach dentists so they become more profitable, they go, aren't they profitable anyway?
yeah,
I'm going, yeah. Sometimes they're careless with what they make, and they lose more. So dentists need to be, sadly, because there's not enough of them, they really need to be careful to make sure that they maximize their opportunity of
sure.
wealth creation, because wealth creation is
Mm,
what then feeds their community. That it's where they live, it's where their children go to school, it's what they spend their extra money on. That feeds the community. And so
mhm.
dentists need to be sure that they're doing that, but they also need to be sure that they're not being um, wasteful with their money and
Yeah,
giving it away and having it stolen from them by
right.
um, because they're an easy
Well,
target.
yeah, and providing services of value, communicating the value. I mean, I never had a problem with enrollment of anything that was not uh, paid by dental benefits, because I believed in what I was offering my patients was the best thing for them. We were talking about maxillofacial and oral cancer screening, and there's that big lack of how that's being done. And what if we had a higher level of screening and we charged something for that package? Say it is a Panorex, and a fluorescent light that can detect lesions earlier. And we have that offering. Patients will pay for that stuff all day long if we communicate it right. Or say we have a CT machine and we're giving those CTs away because we know dental's not going to pay for them. Well, if your MD said to you, okay, I see something on this 2D image that doesn't look right, and I need a better look at it, I'm going to send you to the imaging center and they're going to take an MRI or a CT. You don't even question it. You go and you get it done. Yet we have this technology in our practices and we give it away every day, all day, because we've been trained by this thing called dental benefits that says we don't pay for that. And we feel bad asking them to pay something. I don't care what it is. I don't care if it's $100. Get something for it. That's $150,000 machine that should be generating some income. And if you say to the patient, I see something abnormal on this image and I need a 3D view of that, I need a CT. Patients understand that because most patients have had something like that done at an imaging center, and they're going to expect that they're going to need to pay for it. Just make it a fee that is reasonable, that you feel comfortable asking them to pay for. I mean, there's so many things that we can be missing without taking an orthopanogram, which is what it's called by medical. If we are dictated by this dental benefit and we can only take an FMX or a PAN every 3 to 5 years, and say when I worked in perio, we took FMXs. What are we missing by not taking that PAN? Maxillofacial and oral cancer. We can't see it all. So and periodontal disease used to be the number one reason for lawsuit in a dental practice, being undiagnosed and untreated. Oral cancers on the rise because we're seeing that because of HPV, and it's our job to screen for that. So we can do tactile and visual screenings, but there's other things that we can do along with that to screen at a higher level, create value in what we do. Patients will love that. They'll go tell all their friends, like you said earlier, oh, my dentist doesn't do that.
Yeah.
That's you start talking to people and they're like, oh gosh, my dentist, I don't think they've ever done that. Or if they've done it, they haven't verbalized what they're doing and what they're feeling for, and like walking the patient through the process so they understand and value what we're doing, because nobody wants to talk about the C word, cancer, that is. Nobody wants to talk about that. And yeah, it's a scary term, but patients need to understand that it's important that we screen for that and that we do a really thorough job of that. And part of that should be an orthopanogram at some point. So coming up
Well,
with a protocol around that, and then having a fluorescent light. Let me tell you, there are many oral physicians that don't believe in fluorescent lights for maxillofacial, not so much maxillofacial, but oral cancer screening. And when my mom had lung cancer several years ago now, when they had her on the table, they used a fluorescent light just like that to check all the lobes of her, all the other lobes that didn't have cancer, fortunately. But they used the same fluorescent light that we now have that we can use in the mouth. And I've even had a dentist use it on his back. His daughter, who's also a dentist, he said, I got this little spot on my back, shined a light on it. It was about this big. Sure enough, when he went to the dermatologist, that's how big the lesion was that they cut out of his back. It looked like a little dot, like a little mole or something, but it was big. And he's like, from now on, like I screen my whole body with that thing, because it does show us stuff we can't see. We can't see that underneath that top layer of skin. We can't see. We're flying blind without this technology. And now we have salivary testing. Those are things that we can build those things to medical.
well,
Like
that's
we have
important.
the technology. Let's use it.
Yeah, if we can bill it to medical, that's really, really, really good. It's sad that when we can't bill it to medical, people delay the testing. rather than
Yeah.
pay it out of their own pocket.
Yeah.
Even just getting back to panoramic X-rays more
Mm.
regularly than every 3 to 5 years for perio. That's in 3 to 5 years, they're
That's too. Uh,
it's way
they need one. Yeah. And
who
and not
decides that?
everybody needs, yeah, and not everybody needs the same treatment, right? So but we often go by what their benefit is, and so we just do it every 3 to 5 years instead of when is it truly medically necessary for that particular patient,
Mm,
you know.
exactly, and the medical need should override the financial
Mhm.
who's paying for it. Uh,
You could take a CT every day, or a pan every day, or a lateral ceph every day, and bill it to medical as long as it's medically necessary.
mm, but in dental, you can't.
No, because dental comes with a lot of limitations, exclusions, and not that medical doesn't, but it's a much fairer game. And we're not tapping it. We aren't trying to, get that $1,000 benefit a year. We have there's unlimited amount of money on the medical side.
It's
Um,
it, it,
it's
it,
crazy.
we need to be tapping into it because we need to be helping our patients save their own lives. If
Hmm.
there are things there that we can be testing for, that the tests are helped paid for by medical billing, that are going to keep our patients alive by finding those things early. And you touched
Right.
on just then the salivary tests, and
Yeah.
that's something that I had done earlier this year as a result of talking to an American company, and they said we're trying to get dentists to, when they confirm their patients' appointments, to send their patient a questionnaire, as I just did this morning for a dinner that I've got booked for Friday. They went through the whole thing of, you're arriving at this time, you've got 2.25 hours in the at the table, then we're going to need the table, and these are your pre-requirements. So that questionnaire for me was about um, saliva testing and oral cancer um, predisposition. And so it said, were you ever a smoker? And it's probably the biggest regret of my life that I smoked while I was at university. So that's a long time ago. It's 40 years since I gave up smoking, but I smoked for 5 years, 6 years, and I regret, if there's one thing I could change in my life, that'd be the first thing that I would change, that I never ever
Mhm.
did do that. Second thing was, do I have an alcohol consumption? Yes, I don't drink during the week, but on weekends I'll have a glass of wine and a couple of beers on a Saturday and a Sunday, because it's the weekend. And so that
Mhm.
raised my risk as well, plus a couple other questions. So all of a sudden, I'm getting this test sent from America to me. Uh, the company, I paid for the test myself. Company sent it to a dentist in America because they don't send them to Australia. So he had to mail it out to me. I had to mail it back to his office. It was organised
Mhm.
by the company. It got lost.
Oh
When it got
no.
back to their office, it's like, where's this? Who's got it? Whatever. But anyway, they found it. Um, Long story short, no oral cancer predisposition in the markers that they were looking for, but I still went through the other saliva indicators for um, just periodontal issues and caries issues, and
Mhm.
then discussions with a dentist on staff with that company about, because I am a dentist or was a dentist, I have very good oral hygiene habits. So, and I also
Mhm.
have very good dietary habits. So the fact that I had markers for caries, if I'm not feeding it sugar and I'm brushing and flossing 3 times a day and I'm visiting a hygienist 4 times a year, I'm probably not a high risk of decay, but I'm still very on top of the periodontal issues. But interestingly, I'm outside the spectrum in terms of how thorough I am with my oral health. To get
Right.
to my age and still only have a DMFT of 4, I've got 2 crowns and two DO cavities filled. That's it, nothing else. I've got a
Mhm.
mandible free of 16 teeth, no decay. So I'm pretty proud of that, and that's by choice and habit.
Right.
of diet and keeping clean. But the fact is that I love the fact that we now have salivary tests that can help our patients make that decision. I need to
Right.
change what I'm doing as well.
Right.
And so if we can build that through medical, then our patients are better off.
Well, and what about, so you mentioned something, Caries risk. Caries risk should also be in our regimen of things that we test for. And there are ways to do that. And it should be in our arsenal on every single patient. And we should be doing it. Caries is the #1 disease in the world. In the world. Yet what are we doing about it? I mean, if anybody is on a medication, you're almost automatically moderate caries risk, because medications these days cause xerostomia.
Yes.
And then you put in there that they don't floss every day, or I mean, it is so easy to get to moderate or high caries risk. I'm high caries risk. I'm a hygienist. No, I'm not. I'm a oral professional, whatever. Um, I, but what are we doing about that? What are we giving our patients to try to prevent that? And, there's always going to be patients to take care of. There's always going to be restorations to do, implants to place, ways to make money in a dental practice. But we can do all of that. But if we're not helping maintain it, I have a problem with that.
Yeah. We do need to be, as dental professionals, we do need to be more broad spectrum in terms that dentistry is part of total health, and it's not just about fixing broken teeth. And yet there are still dentists out there who would rather fix a tooth with a periodontal condition than fix the periodontal condition first and make sure that
Yep.
tooth is sound. And that's really, really sad.
Let's build on sand. That makes a lot of sense.
Oh, yeah. Well, how many times do you still see that little cartoon where the dentist is saying, "But your breath is so bad," and they go, "I just want tooth whitening. Do you do tooth whitening?" But that's again, that's the
Priorities
public
for
education.
patients. Yeah.
That's all they want. I just want white teeth, but your breath is. You've got. I can tell that there's illness in your body because of that.
Yeah.
It's
For
really sad.
sure. Infection.
Well,
it's pure infection.
It's an uphill battle. It's one of those questions that you're going to ask. Have you ever been talking to somebody and they take a step backwards?
Yeah.
Why do they do that? It's your breath.
Yeah.
What's my bad breath? Did I eat something? No, it's because there's illness in there.
Yeah.
And it
Absolutely.
could be illness in the gums, or it could be a systemic thing coming from down in their throat as well.
How often have you been on a plane and you know that the person next to you has an oral infection? All the time. Happens every flight I've ever been on. It's crazy. And again, when you look at the stats of periodontal disease, and at least 50 to 80%, depending on the age bracket of people, have periodontal disease. I mean, what are we doing? And same thing with caries. I mean, caries, there's things that we can be doing to prevent, because that caries will eventually, it's an infectious disease in my opinion, because it leads to infection, and it's going to harbor bacteria that leads to infection. But yet, we're not even doing the basic caries risk assessment and trying to treat it even that level. So just expanding and getting our profession out of the grade level C and going above and beyond standard of care, because standard of care is just getting by. At least that's my thought. I lost you for a second there.
No, that's okay. You were talking about standard of care. I did too. It maybe picked up in the recording independent, but just repeat anyway,
Yeah.
just in case it wasn't. You were talking about
Yeah.
standard of care.
So yeah, I mean, standard of care to me is always been level C, grade level C. And it's really about how do we get ourselves at a higher standard of care, like, and not being just the average. How do we do more for our patients to just ensure their overall health? There's so much more that we can be doing, and we just need to tap into it. And I always believe that you do the right thing for the patient, you advocate for the patient, do the right thing for them, and the practice will organically grow. When you talk
I,
about
I,
growth of a practice.
I ultimately, we get back to that. We do need to be mindful that we do need to be running successful businesses. It's better for our own mental health. It's better for our families to live in a less stressed environment, and it's better for our community. Really, really important. But in terms of oral health, it's hard because the general public can't see what's in here.
Yeah.
But and I say that because they can see what's on the outside. And
Hmm.
if you look historically at a map of the United States and look at the obesity shading over the last 30, 40, 50 years, they're getting less mobile and everyone's getting bigger in size. And as friends of mine, when I used to travel, because I traveled to the US from 2007 to 2019, 4 or 5 times a year. So I've been to the US like 60 times. And they just said that a lot of the general public, their belief is, well, I've paid my taxes. It's the government's job to keep me alive. And that's that's a really tough way of looking at it. That's like driving your car and never getting it serviced and saying, well, it's broken down,
Sure.
fix it.
Right.
And some people do spend better time looking after their cars than they do looking after their bodies. Um,
Yeah.
when you mentioned about going to the doctor and feeling that there, and he said, "Well, what do you want me to do about it?" Like, you can't even see it. Why did he
Yeah.
ask that? You're at the doctor to get it fixed.
Well, I wasn't there for that. It's just something I threw on top of it. It was
Yeah.
like, hey, just by the way, I can't see behind here. I mean, even with the mirror, I can't really see what that is. Is it anything to be concerned about? Because he was a dermatologist, you
Mm.
know. He's like, oh yeah, you've got a pretty big cyst there. I'm like, he's like, it doesn't bother anything, but if you want it removed, that we can take it off of there. I'm like, yeah, I want it out of there. I'm like, so, he socked me for it, which is fine. I didn't expect him to do it for free. And I also didn't ask how much it was going to cost. I just wanted it to be gone. That's
Yeah,
all.
I had a similar thing. I had a BCC on my back and was booked for the surgery on that and a couple of moles to be removed. And I had a little tiny little like a looked to me like a papilloma, uh,
Uh-huh.
just up here. And the doctor said, uh, you know, prior to the day of surgery, she said, I'm just going to do a punch biopsy on that and we'll see how it is. And when on the day of surgery, I said, why not just take it out? She goes, well, I can take it out. Would you rather I do that? I said, well, you're cutting 5 things off my back. May as well do this. And she did such a neat job in terms of working with the lines I already had there, as opposed to creating any more, that you can't see it. Um,
Yeah.
but it was also a BCC, so it wasn't a punch biopsy. Would have just been an extra procedure because it would have had to come back and have it taken out. And
Right.
so
Right.
again, it was just something that you could feel but not see. The one on my
Right.
back, that was that took me there in the first place. This is like you. I was playing golf and I was wearing a white shirt. And at the end of the day, somebody said, "You're bleeding on your back." And I go, I must have, I said, I must have caught myself on a tree, but I hadn't been in the trees. I'd actually played some really good golf down the middle. And it was really weird. So I thought, I wonder, anyway, I got like you, I got my daughter to photograph my back after I'd gotten home. And I sent that to my doctor and he said, oh, yeah, it's a BCC, get it out. But it wasn't until I had it out, and then you've got to wait for the stitches to heal, and then I started playing golf. and on my follow through with the driver, it hits me on the back, right on that spot. So that's what made that lesion bleed. So anyway, long story short, I'm still here. That was 2011, so I'm here 13 years later, fine. But
Yeah.
Kandra, we're getting towards the end of our time. We've had a great chat. You said after we spent so long in our pre-chat that we could talk all day, and I'm sure we could talk all day. It's been a pleasure talking with you, and we have raised so many interesting topics in dentistry that a lot of dentists don't even think about because they're in that narrow mind of there's a hole, let's fix it. And yet there are we have so much impact that we can have as dental professionals in terms of helping our patients by being able to find things that are systemic, that have indicators in the mouth, and also helping them to keep their teeth longer by looking after their periodontal health, and the relationship that we have in terms of helping to subsidize the cost of the diagnosis and the cost of the treatment by being aware that some things, especially in the United States, are available to be billed to medical billing as well. So it's been a really exciting hour talking with you about all this opportunity, because at the end, our patients benefit from our extra knowledge of what we can do for them and how we can help them to prevent big problems happening later by just being on top of our diagnostic procedures. Kandra, thanks so much for being a guest on the Ultimate Dental Podcast. If somebody wants to get in touch with you, what's the best way?
Go to my website. It's tipsmedicalbilling.com. So TIPS medicalbilling.com. There's a reach out contact page. That's the easiest way to get in touch with me. And I'm more than happy to do a complimentary, what I call MBA or medical billing analysis. If you've watched this and you want to learn more and you want me to really analyze your numbers and the opportunities that I see for your practice individually, just let me know. I'd love to talk with you.
All right. That's the best way. And you're also on LinkedIn a bit too. So that's how we met. So, that's another way to get in touch. But Facebook as well.
Facebook, LinkedIn. Yeah, that's and obviously my direct website. And my website has many resources, things that I've wrote, CEs that you can take and learn a little bit more. All sorts of resources on my website that you can kind of check into, see if you resonate with what I have to say, and then reach out.
Well, certainly anybody who's watched this podcast or listened to this podcast should be reaching out. You have created, I guess, an opportunity for people to just expand what they're doing for the benefits of their patients and ultimately also for the benefits of growing a healthy dental practice. So, Kandra Sellers, thanks again for being a guest on the Ultimate Dental Podcast.
Thank you so much.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth. your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.